We have one more presentation before our next break. We're now going to hear from Nikki Goff, ARNP, who will talk about the sexual health consequences of gynecologic treatment. She completed her Doctor of Nursing practice in 2020. Her DNP project focused on sexual side effects following gynecologic cancer treatment and how to incorporate the topic of sexual health into routine gynecologic cancer follow-up.
I am a nurse practitioner at the University of Iowa. I've been with the Department of Gynecological Oncology since 2014. I currently practice at the Women's Health Outreach Clinic in Davenport, Iowa. I completed my doctorate of nursing last year, and the degree required a scholarly improvement project that focused on a change that would impact healthcare outcomes. We had to evaluate the outcomes of the project or the intervention to determine how it would help guide future practice, and it should have been able to provide a foundation for future practice. So I am going to review that project with you today. I have no financial disclosures. Objectives are to identify sexual side effects resulting from gynecologic cancer treatment and name resources available to help manage those side effects. I attended the All of Me conference in May of 2018. At that time, I learned that gynecologic cancer treatment negatively affects sexual health and that it is rarely being discussed with providers. I began screening my gynecologic cancer patients at routine surveillance appointments and provided them with treatment recommendations for their symptoms. I documented this information in their clinic note, and at follow-up appointments, I would document whether the patient was still having symptoms and what interventions they were using. So for the intervention, it involved screening, which was the discussion and the introductory message, basically saying that sexual health is important. It can be affected by cancer treatment. Are you having any issues with your sex life? It also involved the assessment of the vaginal and vulva areas, as well as the treatment recommendations provided to the patient. There's a few listed here. So the purpose was to determine if the intervention of discussing and providing treatment recommendations improved sexual symptoms 3 to 6 months post-intervention. The goals are to improve sexual health for the patient and implement the intervention throughout the department if it was found to be successful. So a quick review of literature. Gynecologic cancer treatment affects sexual health. This includes decreased sexual function, decreased feelings of femininity, changes to body image, changes to intimacy, relationship disruptions, and affective well-being. It also revealed that patients with low-risk cancers were suffering from side effects as well. Patients lack support in addressing their sexual symptoms. They have unanswered questions, and they are uncomfortable asking providers or initiating the conversation. Providers lack knowledge in discussing sexual health. There's also a comfort level issue and time constraints. Many providers do not receive any training on how to discuss sexual symptoms with patients, and oncologists in particular have very little training in this area. There's no recommended screening tool. There are plenty of questionnaires out there, but many of them may not be sufficient in addressing all areas of concern. So I performed a quantitative exploratory retrospective chart review using purposive sampling, and my inclusion criteria will be included on the next slide. So I obtained approval from the University of Iowa, where the project took place, as well as the university that I completed my doctorate at. Then I reviewed medical records. Look for the inclusion criteria, which was female patients 18 years and older who were seen in the clinic May 1st, 2018 to May 1st, 2019, had a documented diagnosis of gynecologic cancer and received treatment for that cancer. They received the intervention. They returned for follow-up 3 to 6 months later, and that the symptoms were reassessed at that visit. This information was then placed on a data collection sheet as follows. So the different types of gynecologic cancer, the FIGO stage, the treatment that they received, their sexual complaint following their cancer treatment, the sexual treatments that were recommended for their symptoms, and their symptom reassessment, which was coded as 1 for improved, 2 for worsening, and 3 for no change. The sample size included 21 participants. Ages ranged 36 to 79, with a median age range of 55 years. So there were 13 patients with endometrial cancer, 3 with ovarian, 4 cervical, 1 vulva, and no patients in the study had vaginal cancer. The majority of the patients had stage 1 cancer. No patients had stage 4 cancer. All of the patients in the study received surgery. And then there were 3 that received surgery and chemo, 4 with surgery and radiation, and 3 with surgery, chemo, and radiation. So for sexual symptoms, 81% of the participants reported dyspareunia, 5% reported decreased libido, and 14% reported a combination of the two. SPSS was used to enter the data, and a z-test for proportion was used to analyze the data. 11 participants, or 54.2%, reported improvement change, whereas 10, or 47.6%, reported no change in their symptoms with their intervention. No patients reported worsening of their symptoms. So this was the z-test for proportion with a level of significance of 0.05. This generated a p-value of 0.0126, which is statistically significant. So strengths of this intervention is it was performed at routine follow-up visits. A separate visit was not needed. It was well accepted for the most part by patients. It was easy to use, and it involved a very short time frame. Some barriers included time constraints and comfort level of the provider as well as the patients, and this is consistent with the review of literature. Other barriers include discomfort with the treatment recommendations provided, and this may have been because the patient had such a long time interval between when they had treatment to when the discussion took place, and they just weren't motivated or they felt embarrassed to initiate any of those recommendations. So just a little discussion. The study did indicate that females suffer with sexual symptoms following gynecologic cancer treatment, and it's important to screen for sexual concerns and provide treatment options. This helps to raise awareness of sexual symptoms. It also provides patients with a sense of relief to know that this is common and they're not alone. And it also aids in discussing the topic and making it more comfortable for patients. Furthermore, implementing this intervention would coincide with evidence-based standards, including the American Society of Clinical Oncology, which states that providers should be screening patients for sexual dysfunction during routine visits, as well as the Institute of Medicine that states that sexual symptoms should be included in the survivorship cancer plan. So some implications for patients: it would provide comprehensive patient care, it would improve sexual symptoms, and it would also improve quality of life. So I recommend that we educate all providers about the possible side effects of the gynecologic cancer and the treatment options out there to help aid and manage their symptoms. I recommend that we discuss this prior to cancer treatment, so it raises early awareness and helps normalize the conversation early on. And I also think that it should be incorporated into routine practice by screening at every visit, so patients become more comfortable discussing their concerns and also utilizing the treatment recommendations and resources provided. Thank you. Here's my references for my study.
Thank you, Dr. Goff. And thank you for all of the great work you do with our GYN oncology patients. One of the things I really love about your study and some of the things you're recommending are the idea of incorporating it into a routine follow-up visit. Because as a provider, even with patients who have known sexual dysfunction, I really find that it's a struggle sometimes to get them to accept coming back for a specific additional clinic to focus on sexual health. So I think anything we can do to incorporate this into routine visits that patients are already coming to can be really quite beneficial.